Okay. So I'd like to welcome you all to this webinar today on quality management and service accreditation and physiological measurement. This is organised by myself, Duncan Middleton and Kirsten Graham here in Glasgow, and is a follow-up to a seminar we had in January on a similar topic. Today there will be two talks by and then questions afterwards, and the talks will be given by Dr. Laura Booth, who's a UCAS Senior Assessment Manager, and then the second talk will be by Anne Davies and Liz Macaulay, who are IPEM and MPACE technical assessors respectively. A bit of housekeeping before we get started. The webinar will be recorded, as it's just started. Any questions you have during the talks, please put them in the Zoom chat, but during the question and answer session at the end, it will be possible for you to speak to the speakers directly and verbalise your questions. And can I ask that during the presentations, everybody stays on mute. Oh yeah, so that's me doing my introduction. And so we'll get started with the first talk, which is UCAS Accreditation in Healthcare, which is by Dr. Laura Booth, a UCAS Senior Assessment Manager.
Perfect, thank you so much. Hopefully my screen sharing. Oh, has it stopped or is it still sharing? There we go. Okay, can we all see that? Is that all right? Perfect. Right, so welcome. Thank you so much for attending and for inviting myself and my colleagues, technical assessor colleagues. It's really exciting for us to be able to share with you what we do within UCAS and from the perspective of quality improvement. So my name's Laura Booth. I am a senior assessment manager for UCAS. I've worked with UCAS for 9 years now. My background is actually audiology, and I run the IPEM scheme itself. So that's the Improving Quality and Physiological Services scheme. But I am going to try and cover, obviously, the MPACE scheme as well, which is the physics and engineering side of things. But my knowledge around that is less so than for IPEMs. So hopefully what I'm going to try and get across to you today is understand a little bit about UCAS, who we are, what accreditation does, why it's important, understanding a bit about the IPEMs and the MPACE scheme and the standards that relate to those, talk you through a little bit about the accreditation process, and then the impact that accreditation actually delivers on service quality. So hopefully, you can get a good understanding about the journey, the benefits for you, and actually how you might want to start thinking about moving forward with accreditation if you're not already involved. So why does accreditation matter? So accreditation provides confidence in everyday life. So as UCAS, we are the sole accreditation body for the UK, and we are commissioned by government. We're not part of government. We are an independent non-for-profit organisation, but we have a memorandum of understanding with government to deliver accreditation activity. And it's really important that accreditation exists, because what we're doing is providing impartial, independent assessment of organisations that deliver activity or services that are providing public interest activity. So we cover a huge range of areas, not just healthcare. We provide certification, we provide inspection, accreditation, alongside the accreditation of things like healthcare. So for instance, if you think about what's gone on in your daily life so far today, a lot of all the things that you rely on to keep you safe have been underpinned by accreditation. So for instance, your drinking water that you drink on a daily basis, that goes through treatment works, through laboratories that are all assured through accreditation. The buildings that you're in, again, construction work, all underpinned by accreditation. Same with bridges that you go over, making sure that those are safe and fit for purpose. And also the cars that you drive, the inspection bodies around the MOTs to make sure that they're safe for you to be driving. So accreditation covers a massive area across the whole of public interest activity. Within healthcare, it's a growing area of the organisation and for business. We've accredited medical laboratories services for over 25 years, but within healthcare, we've got new schemes developing all the time. And MPACE being more recent, one of the more historic ones is the imaging standard and the imaging scheme that was developed in 2009, and then the IPEM scheme for physiological sciences in 2012. And we're constantly having development projects underway within UCAS. So at the moment, we're working with the sexual assault referral centres to ensure that accreditation can underpin the outcomes of laboratory tests within those centres. And quite shockingly, I found out that apparently less than 1% of convictions actually get convicted, often due to the lack of assurance in the controls around those sort of tests in place. So it's really important that accreditation is there to give confidence to your patients at the end of the day, but also to you as an organisation and as a service and your stakeholders. And UCAS can provide that impartially, independently, so that you're not ticking your own homework. You've got someone coming in and actually making sure that what you say you do with confidence. And the fact that it is the UK Accreditation Service, we run accreditation activity across the whole of the devolved nations, but we also do international work as well, working with accreditation bodies in different countries to ensure that we can keep accredited activity delivered either in the UK or internationally. So as I briefly mentioned, we're a non-for-profit organisation, so any of the profit made within UCAS goes back into the business to support development projects. And that's very much around the MPACE and the IPEM scheme. There's still, although IPEM is in operations, it still is not making a profit yet for UCAS and is supported by the rest of the business, as is the MPACE scheme. So what we do within UCAS, we design and administer robust and consistent assessments and the accreditation process. So if an organisation or someone comes to us to ask whether they can have a particular activity accredited, we look at that and determine, first of all, is that in the public interest, and what sort of standard there might be out there that activity can be accredited to. And we might need to develop a scheme around that. And that's what's happened with IPEM and with MPACE. We provide competent independent assessment resources. So we have internal permanent assessment managers, and they are case managers that manage you as potential customers from different organisations, and they arrange the assessments, and they generally will be the lead assessors as well when they're on the assessment with you, looking at your management systems. And then we have approximately 840 external technical resource assessors. And those assessors come from your own backgrounds, from your own disciplines, because obviously my background being audiology, I would not be able to assess technically for any clinical engineering, but I could be the lead assessor to look at the management system around that. But I would rely on someone from your own expertise to support me in understanding the clinical input and the technical input and whether that was being delivered appropriately. So what is accreditation? It's the procedure by which an authoritative body, which is us at UCAS, gives formal recognition that you as an organisation or potentially people are competent to carry out those specific tasks. So we have those independent impartial assessments, and when you engage with accreditation, that assessment, once you've been granted, becomes an annual process so that we can make sure that you are conforming to the standard requirements consistently over each year. You have to demonstrate the technical competence and impartiality of your organisation, and it gives confidence there when you're accredited to all users of that organisation's services and helps to reduce the risk that's around that activity that's being delivered. It might also identify service improvements. So we've seen lots of assessments, certainly within the IPEM and MPACE arena, where improvements and developments and innovations can come from accreditation. Also supports NHSE requirements. There's more drive from NHS England at the moment for all diagnostic activity and services to become accredited to provide that confidence. And because, again, UCAS being the sole accreditation body, that will mean equitable confidence across the whole of the different activities. You might find that you have a benefit of accreditation because the output is recognised nationally and internationally. And there may be contractual requirements. So as I said, certainly the clinical diagnostic centres at present, there is actually a contractual requirement for the diagnostics around cardiac physiology and respiratory and endoscopy and some of the medical laboratories to actually have accreditation within 2 years of that being set up. So with regards to accreditation, the idea is that we want to have confidence, trust and assurance in the activity, the processes that you're delivering. That might be around a product or a service, and it may be around the people or the management systems or organisations. So essentially there are regulatory standards in place. So there are many ISO standards, there are British standards, and then with regards to the IPEM scheme, there's a national standard that's been developed, and the same with the imaging scheme. And those standards are then assessed either through certification, verification, validation, inspection, or testing or calibration. And we as UCAS would then assess the organisations against those standards. And UCAS itself is actually independently assessed every 4 years by peer international assessors who come and assure that our management systems, our assessments, our processes are fit for purpose and meeting our own standard requirements, which is 17011. So within healthcare, we're a really expanding area of the organisation at the moment, as I mentioned. We've got the imaging standard, which is now QSI. We have, at the moment, the things that are important to you are the medical physics and clinical engineering, MPACE, which is accreditation to a British standard, BS 70,000. And then we have physiological diagnostics, which is the IPEM standard. And that is a national standard that is owned by the Accreditation Clinical Advisory Group that formerly came from the RCP. We also have accreditation in medical laboratories to 15189, which again is an international standard. It's point of care testing, dental service certification. I also perform inspection body assessments for inspection bodies assessing care homes, making sure that they're providing fit for purpose care for people in those environments. Conformity assessments for medical devices, and then we have clinical EQA schemes as well. There are other areas outside of that, like forensics, which is growing, and as I mentioned earlier, development schemes such as the sexual assault referral centres. This is a really useful document for anyone who's interested in going forward with accreditation and wants to understand a bit more about the process. If you access this on the UCAS website, Gen 1 is really the Bible, the general principles about how an assessment for accreditation, how the accreditation process works. So I would encourage you all to maybe download that, look at that, pass that around your teams if you're interested in moving forward. So just to give you a quick overview, so BS 70,000, as I say, is a British standard, so it is recognised, owned by BSI, and that is being utilised around the MPACE clinical engineering side of the standard and scheme, and that's what's used for that scheme. Then the IPEM standard also is developed. It's not owned, as I say, by a particular body. It's owned by the Accreditation Clinical Advisory Group, and they formed out of the Royal College of Physicians. They work on advising and managing that standard. And there may well be a direction of travel that the IPEM standard might actually transition to BS 70,000 in the future. So actually, they're very closely aligned. But both standards have clinical and sort of managerial requirements. So the specific management requirements, they're very much around governance, looking at the organisational controls, the structure of your organisation, of your service, how you deliver your service, what your objectives are, how your quality management system works. Are you looking at controlling non-conforming work? Are you performing audits? Do you have any management review to analyse how your organisation, how your management system has worked over the last year, and also in order to plan for the next year? And it looks at your suppliers, subcontracting, sort of improvement, training processes, competence processes. So a lot of that is very generic in BS 70,000 and IPEM, so the two are very harmonious. And then the same really with the technical requirements. So when we're looking technically, we're looking at personnel, looking at their training, their competence to deliver what they do, looking at methods and procedures, what QA have they got in place, what equipment's in place, is there calibration, is that effectively measured, is there equipment traceability within that, uncertainty of measurement criteria, looking at the accommodation that you're providing activity in, how you're handling particular systems, and reporting outcomes with regards to the activity that you deliver. So again, very transferable. And the benefit of BS 70,000 and IPEM is that the two, because they are quite aligned and the standards are aligned, it means there is the opportunity for us to be able to look at performing assessments for an organisation for both standards at the same time, so that again, that can be a cost-saving, time-saving mechanism for you moving forward in the accreditation process. So the IPEM scheme and standard itself, just to touch briefly on this covers 8 different disciplines. So it covers audiology, neurophysiology, respiratory and sleep, the cardiac physiology, vascular science, vision and ophthalmic science, urodynamics, and, oh, I'm missing one, GI physiology. So all 8, I have to try and remember them all. All of those disciplines are currently accredited, with the exception of vision science, and we have a pilot going through at the moment, so we're hoping we'll have our first vision science service accredited early in next year. Again, the benefit of that is thinking about where your departments sit within an organisation. You may well have links with neurophysiology or audiology or vision science with the electrophysiology side. So again, that might be where you can start thinking about combined assessment approaches and where there's some overlap. So the IPEM scheme itself was developed in 2012. I've mentioned the ACAG. We currently have 67 organisations accredited. That covers 81 disciplines. So some of those organisations are accredited for more than one activity. So it could be audiology, GI physiology and neuro in one organisation. And again, the more that you cover, the better, the more effective it is, the easier it is for you, the more cost effective it is. MPACE, so again, to give you a bit of an idea around MPACE, so the British Standard 70,000 was published in January 2017. So MPACE is the scheme for medical physics and clinical engineering services. This is much newer within UCAS, within development. We've currently only got 3 accredited services, and at the moment only looking at radiotherapy physics and the clinical engineering side, but there is a look to expanding that at the moment into nuclear medicine and into other areas that are covered within medical physics and clinical engineering. And that can come on as extensions to scope. So we actually have still got quite a few expressions of interest in the MPACE scheme, and we've got 2 to 3 of those accredited services now, 2 out of 3, who are looking at putting in an extension to scope to expand their scope of accredited activity. You can put in an extension to scope to expand on activity that you deliver. So you might decide to come forward for accreditation just for one location that you deliver at, or just for one type of activity, so like the radiotherapy physics and maybe just adult audiology, for instance. But you can bring on at any time, once you're accredited, any other locations that you deliver at, or any other activity that you then want to bring on into the scope of accreditation. And we try and build that into your accreditation cycle and your process. So the assessment itself, how it works, so UCAS accreditation, we have regular independent assessments with awards of maintenance of accreditation. So that's once you've become accredited with UCAS. You're contracted into a defined process with us, and every assessment is conducted by impartial technical, peer and lay assessors, all managed by a lead assessor within UCAS. You have informal and formal assessment that leads to a recommendation. So part of the assessment process will be that you'll be required to upload some evidence into a SharePoint repository prior to an assessment, and the assessment team will review that and get familiar with those processes, with how you manage things, and then we will perform either an on-site or remote assessment depending on the year-in cycle to determine the level of conformity and do you do what you say you do, essentially. And then there'll be ongoing assessments, as we say, annually. We do have the ability to put sanctions in place. So there may be a time when an organisation isn't meeting the standard due to maybe a lack of resource or some significant issues and non-conformities. So we might have to suspend some accreditation, might be part of a service is suspended, or it might be the whole service. And that allows an organisation then to work on those areas and come back on board in a time frame that's appropriate for them, but it minimises the risk. It doesn't allow them to be shown as being accredited when actually at that time maybe there are things that need to be implemented to meet the standard. We have got accreditation support in place. So with regards IPEMs, we have you can contact an assessment manager who can give you an initial assessment of costs. We have a standard awareness course that's available for IPEMs so that you can understand the requirements of the standard and what's needed. For MPACE, we've got an assisted application service. So as part of the application fee, you would get training modules to understand what's expected. You get some remote learning and access to material to support your business cases, your development. And that's sort of free, that registration, and it's valid for 2 years within the process. So when you apply to UCAS, in an ideal world, we want to see you progressing within a 2-year period to be having your initial assessment. And we might consider withdrawing that registration if we're not seeing that progress. We have a reduced initial assessment day rate compared to other UCAS customers, so it's a discounted rate for MPACE and for IPEMs customers at the moment. And the initial assessment costs are very much based on the effort that's required. So we can give you a ballpark figure, you can ask us for an estimate, but it will vary depending on the scope of application that you've put in, the number of locations, and the level of staff across those locations as to what we need to see. So you can, as I say, complete modules as you go along to sort of give you an idea of what the improvements you need to make on your service before you move forward. You can also have a pre-assessment with UCAS. So within the preparation process, once you've applied to us, you have an option of a pre-assessment visit. And we would suggest that this is recommended and that you take that on, because that allows us to do a review of your management system. It allows a technical assessor to come and have a look at your organisation, to look at some clinical activity and to highlight if there's any gaps that you haven't maybe picked up yourself, and give you a really good idea as to whether you are really ready for that initial assessment. Hopefully a lot of that preparation will help give you that guidance, but the pre-assessment is really sort of valuable because it doesn't give you that sort of negative potential of if for some reason you were not to be able to be recommended at initial assessment. The pre-assessment at least gives you the guidance of where to go. Then you would have an initial assessment, so subject to the pre-assessment going well and you being ready for your accreditation. The initial assessment is always on site because we want to be able to physically see the organisation's facilities, equipment, processes, and that's usually an assessment manager who acts as the lead assessor, a peer technical assessor or more peers depending on the scope of your activity, and a lay assessor. So it's really important that we have that lay input because that's a requirement for CQC to recognise the accreditation schemes, and actually the lay assessor provides some really invaluable insight into the patient experience that goes on within those services, and they can see things sometimes that those of us who have clinical backgrounds maybe don't necessarily pick up. And that initial assessment's usually over 2 days. So we would be on site for 2 days and we would have an opening meeting. We would have the full-on assessment with the lead assessor going through the management system areas while the peer assessors are reviewing the activity that's being delivered. Then we would come together and we would have a closing meeting where we would provide you with the recommendation for accreditation. So I've just jumped through that one for you. We would, within the initial assessment, where we see an organisation that maybe doesn't conform to the standard, so there's an area that isn't conformant, or their own processes, they don't conform to their own systems, we might raise what's known as mandatory findings. And those are the findings that you would need to provide evidence to UCAS for, to ensure that they are closed out and they don't reoccur and they're actioned, for us to be happy that you would maintain conformity to the standard. You would get 3 months at an initial assessment to actually close out that evidence. And we always ask you as an organisation, what is it that you feel you should provide to close that finding down, because it's not going to necessarily be the same for every organisation, and we can't tell you what you need to do because that would be consultative. And also, if we told you how to do something and you implemented it and it didn't work or it wasn't fit for purpose, you know, we would be assessing our own systems, and you could come to us and say, well, you told us to do this and it didn't work. So we're very much working with you so that you can agree improvement actions for how your processes work, because it isn't a one size fits all. And I think that's the beauty of assessment against the relevant standards that we use, is that we're assessing how your organisation manages those particular areas. So for instance, patient information, your organisation may well manage that differently to a different organisation, and neither is right or wrong. As long as it meets the standard and we can see that the process is effective, then that's absolutely fine. That's what we're looking for. Once an initial assessment's been completed and we've made a recommendation to you that we would like to offer accreditation, all of the evidence that we have gained is sent to a decision maker who is independent within UCAS. And we would send you an assessment report that goes through all of the findings, all of the evidence that we've seen, and that is accompanied by improvement actions that you would then work on and submit evidence to clear. So over that 3-month time frame, the decision maker is reviewing that and making sure that the team have done a robust assessment. They've covered all the things that they should have covered in order to be able to offer you that accreditation. Once you've submitted your evidence and the team have then closed that out to be happy that all those areas of non-conformity have been appropriately managed, you will then be provided with the grant of accreditation, again through an independent decision maker. So it's making sure that that process is constantly, independently robust, and that everything is fit for purpose. Once you've been granted, you will fall into a 4-year cycle of accreditation. So 6 months after your grant will be your first initial surveillance assessment. That falls quite quickly after the grant because it has to fall into a cycle from a year since your initial assessment. But once you've had that surveillance 1 assessment, you fall into a 4-year cycle with year 1, year 2, year 3, and then a reassessment again at the year 4 stage. So the impact of accreditation, just as an overview, accreditation can assure efficiency and validity of the processes that you've got in place. It makes sure that your measurements that you're achieving are accurate, and actually, you know, what you say you do is effective and the outcomes are what they should be. Demonstrates the technical competence of your organisation, so making sure that you've got good processes in place and that actually, again, when we observe staff, they really are competent in what you think they're doing. Proves the impartiality and delivers confidence for stakeholders, for users, and for you, again, as managers and service delivery. It allows you the confidence to be proactive and to be risk anticipated in your management. So when you've got systems that are effective and working appropriately, you're going to pick things up quicker before they become an issue and be able to action those. You might get a commercial advantage. So if you do or provide any private work, or if you are actually having to tender for work, then again, having accreditation is that badge of quality that you can use there to show, to get tenders and to gain that commercial advantage. Accreditation might identify efficiencies and cost savings through that assessment process, and we have seen that in many of the organisations that we've assessed, and gives you the ability to promote that reflective practice. So through your management reviews, you can see improvements that have been made, you can look at areas that need to be evaluated and to be worked on over the next year. And you can actually use the assessments as a leverage for change as well. We've had organisations where they know that the facilities they've got, for instance, are not fit for purpose, but they are constantly battling with trying to prove that they need to get those actioned. And so we've done an assessment where we've highlighted they're not fit for purpose, and actually those organisations have then used that and been able to get new accommodation. One recently that I did for a neurophysiology service, they were providing video telemetry in a very small environment that really wasn't fit for purpose for paediatrics. And a result of being accredited and of the recommendations that we made, they got a whole new video telemetry suite. So it goes to show, you know, the power of accreditation. And we work with you very closely to help support you if you know there are areas that you're struggling with. For businesses, you know, certainly adding global recognition, proactive risk management, promotes self-reflective practice, provides confidence to your service users. And as you can see here with one of our IPEM accredited organisations, the statement is everyone thinks you know what you're doing, but it's only when you start looking at those processes do you realise actually how much you can improve and what efficiencies you can make. And I always use the adage of you don't know what you don't know. So until you're measuring, until you're benchmarking, until you've got that information to support that you are doing what you think you're doing, you really don't know whether things are as you think they should be. And then finally there for government, the value of accreditation to government and the public sector, really just giving them confidence to commissioners, to ICBs, to all other stakeholders that, again, what you're providing is equitable across the UK, that you're providing a robust and very clearly effective service. So that's me. I'll bring this to a close because I'm very wary. We've got other speakers and I can wax lyrical forever. That's very much giving you an overview of accreditation, just the schemes that are available to you. I'm very happy for you to contact me directly, and Gilda Stubbs is responsible for the MPACE scheme at the moment, so we've got her contacts there. We'll share these slides with you so that you've got that. But do think about the approach, especially if you've got both types of scheme and activity in your service. Think about those combined approaches and working together, because the more you can harmonise, the more you can work together, the more cost effective, time effective and easier the approach to accreditation will be. So thank you for listening, and I will pass on, stop there, and probably questions at the end, I imagine.
Yeah, thank you for your talk there, Laura.
Thank you.
Yeah, we'll do all questions for both talks at the end. So we'll move on to the second talk now, which is the role of the technical assessor and tips for getting started. And this will be by Anne Davies, an IPEM technical assessor, and Liz Macaulay, an MPACE technical assessor. So I'll hand over to them.
Okay. Thank you very much, Duncan. So I hope you can see that screen share. Does that come up all right? Yeah. Okay.
I can't see the slides.
Okay, let me just try that again. Let me go to here. Oh, share screen. Okay.
Yeah.
How's that? Has that come up all right?
Yeah, I can see PowerPoint. Okay, I'll move.
Thank you. So thank you very much, Laura, for that great introduction. So I'm Liz Macaulay and my colleague Anne. We're just going to talk through what our role is as independent technical assessors and hopefully give you a few tips for getting started on the accreditation journey. So over to you, Anne.
Thank you, Liz. Good afternoon, everyone. My name's Anne, and I work as a principal clinical scientist within audiology. IPEM covers clinical investigations and treatment for patients, and a technical assessor is a senior clinician in any one of these areas. They only assess that area, so I only assess audiology services, not any of the other disciplines. And as a technical assessor, my role is to be in clinic, observing a clinician, doing their usual clinical work, and seeing the interaction between them and their patients. Thank you.
And I'm Liz Macaulay. I'm a consultant physicist with a specialism in radiotherapy physics. So that's the area for which I'm a technical assessor. So BS 70,000, otherwise known as MPACE. Laura's given an excellent introduction there and information for you. It covers a lot of different areas, and in Appendix 2 of the standard, you'll see a list of all the areas it covers. I've put down a few of them here that might be perhaps more relevant for you in physiological measurement. But as Laura has said, to combine the two, IPEM and BS 70,000, might be the way that you want to go forward. So what we do as technical assessors, so as Laura said, we're there with the essential pool of expertise of a particular area so that the assessment that is done is robust and in the relevant depth. So we're there to assess the technical competence and the capability of staff, and make sure that the techniques you're using are valid ones, that the equipment is being used in an appropriate manner, and that staff are not only with an initial competence, an initial sign-off, but an ongoing competence. So as technical assessors, we need to be aware of current legislation and national and international guidelines, as well as current best practice, in order to be able to fulfill our role completely. So the training that we would be given to get us started would be by UCAS themselves in the requirements of the relevant technical standard and of the basics of the technical assessor role. And then we would be mentored in our assessments for one or more times until we could be signed off as competent by a lead assessor of UCAS. There is ongoing competence as required for a technical assessor, and so there is regular update training on the standard and any updates to it, and those are also opportunities that we would have for general discussion. We're working as a team when we come and do the assessments, so we work with a lead assessor and we discuss and advise on the relevant technical aspects of the standard and the application to a particular requirement, and come to an agreement with the lead assessor as to how that is dealt with and written up. And then we are ourselves monitored regularly as well to assure ongoing competence. Handing back to you, Anne.
Thank you. So what we are looking for in a clinical service when they come forward for accreditation, our key area of concern is, how does a service know that their staff are competent and that they're following procedure? You can't just assume that because you've got protocols that staff are following them. You need to be monitoring clinical practice. So as evidence for that, we're looking for both vertical and horizontal audits to show that that's all being looked at and checked. And also we're looking for audit cycles. So we're looking for audits being repeated to check that there's improvement. With all of that, we're looking for strong clinical governance systems to be in place. So if there's errors in clinical practice, that those are being managed effectively and resolved and not recurring. It always worries us if at subsequent assessments we see the same errors in clinical practice recurring. And if we see that, it suggests that the root cause of the error, the reason why it's happening, hasn't been identified. There's also an emphasis in the standard on identifying and resolving non-conformities. It means that we're looking for a service not just to be reporting big incidents, but also niggly ongoing issues, that you're paying attention to why those are happening and looking to address them. Next slide, Liz, thank you. Whenever we assess services as a technical assessor, this is the sort of thing that you would expect, that we're watching all the clinical activity you wish to be accredited for at all the locations, and over time we're observing most of your clinicians, and most definitely those who have a clinical leadership role. And you'll see from the list here that when we are in clinic observing clinical activity, we're also checking facilities, patient information, and that the equipment used is safe and accurate. We're also starting to carry out legacy checks of clinical records as well. So that it's not just what we observe in clinic on the day, but we're also looking at previous clinical records as well. Thank you.
So just to get you started on the accreditation journey, we're looking for lots of evidence. So you might tell us that you do something in particular and we'll say, okay, show us. So your evidence must be demonstrable and available to us. And sometimes we'll ask for evidence before the assessment, and other times it'll be asked for at the assessment itself. So hopefully some hints and tips now on 3 areas that are identified by UCAS on the website. And the first one is technical competence and capability. So through witnessing activities during the visit, we are looking at facilities and environment, as Laura has mentioned. We're looking at the dosimetry, your measurements, and any equipment that needs to be calibrated. Does there need to be a traceable calibration? Is that up to date, etc.? And we're looking for staff to be able to demonstrate that they know where to find that traceability. We're watching the staff as they use the equipment and looking at how they would perhaps perform quality control tests on that, and to assure ourselves that quality assurance of any given process is in place. Any equipment that is used should be appropriately stored and labelled, and also have calibration dates where it was last calibrated and when the next calibration is due. Data storage and security is really important, as is record keeping. So we'll look for evidence of those. So the other side of things is what you're actually doing a valid method? And so there might be different standards of this, if I can put it that way, different levels of that, depending on what we're looking at. So there might be some national legislation around registration or health and safety requirements. So what you're doing matching up to those standards there? Are there national guidelines which people should follow as good practice? So codes of practice or traceability of calibration, calibration cycles. So depending on what the equipment is, there might be some national guidance on how often some equipment should be calibrated. And then meeting good practice. So are you using up-to-date techniques? Do you have external peer review? Your facilities and environment, how is that compared with what we might expect? And what is your record keeping and change development doing as far as your service is concerned? And one of the key things that we look at is communication, both up and down in the department and the service, and how does that work? Then the equipment that you're using, how is that selected? And do you have to commission it before you actually plug it in for its first use? If there's a moving and handling issue around it, can the staff that we are witnessing actually do that moving in a safe manner? And what quality assurance is there of the process? Uncertainty of measurement, a hot topic as far as MPACE is concerned. So I've put it in bold italics there. So any measurement that you make has an uncertainty related to it. And so what have you done around actually recording those uncertainties so that you know what your end result is? Equipment calibration, we've already mentioned, and storage. And around competence of staff. So you might be required to have HCPC registration or be on the register of clinical technologists as a staff member. What training do you need for your role, and is that available to you? And as regards competence records, not only are there records of initial competence, but what is your service doing regarding ongoing competence recording? And that can be more difficult to pin down and start to develop, but it is something that is necessary for accreditation. And then within your service, how are you developing people's skills? How are you developing techniques? And how are those changes brought in? So just as a brief conclusion from my own experience with MPACE, it does need time and effort to achieve the standards required for accreditation and then to maintain them going forward. It certainly requires commitment from not only your local management, but higher up the tree as well, and from all the staff. It's very worthwhile, in my opinion, for not only the employer, but the service and its staff as well, in that people then know what the standard is, what they're required to do, and it's just more transparent throughout. And people then have a more focused experience in their workplace. They know what's expected. It's formal recognition of a high quality service and can help with things like CQC inspection visits. And it does demonstrate competence and its ongoing competence and validity of the methods that you're using. So handing back to Anne for her conclusions.
Thank you. Yeah, accreditation gives an external and independent verification of competency. The difficulty with the staff within the service checking each other or one department checking another is it's only as good as the person doing the checking. And also, if what staff from one NHS trust observe another, if there's serious concerns, it gets problematic as to whether the staff from one trust have got the authority to tell the staff from another trust that things are unsafe. And that has been worked through for IPEM and for UCAS as a whole in terms of systems in place for that. On a lighter note, it's such a privilege to observe and learn from other clinicians' work. It's a fabulous way to share good practice and to work together positively with colleagues across the country. Thank you very much from both of us.
Thank you. I'll stop sharing there.
Okay. Right. I don't know if my video started or not. Does it? Okay. So, okay. Thank you, Anne and Liz, for their talk there. We will now open to questions for both talks. I saw there was one question in the chat from Hugh's iPad. But I think that may have been addressed in the second talk, because the question was, how does UCAS assure itself as to the competence, including relevant skills, knowledge and experience of its technical assessors?
I can add to that one, that's fine.
Okay.
So UCAS has a embedding process for all new technical assessors. There is assurance in monitoring processes. So we have training around UCAS processes. We have training when they're physically on site doing the assessments themselves to make sure that they're following not just UCAS processes, but picking up on the technical skills by using other independent technical resource to make sure that actually they're picking up the things they should do within their own competencies. There is obviously an expectation that technical assessors are maintaining, as was alluded to earlier, any sort of registration, HCPC, all that type of element to make sure that they are competent to do what they need to do. So there is a rigorous process around training, monitoring and risk rating of our technical resource within UCAS. So hopefully providing assurance.
Okay, thank you. Oh, there's another one up here in the chat.
Do we accredit the NPL for its standards work in medical physics, and against which standards is it? Right, I would have to have a look at, because that'll be calibration laboratory, so that'll be under a different standard, which is likely to be 17025. And you can have a look yourself if you want to on our website, but I can try and search and see what they're accredited to. National Physics Laboratory, but I'm sure it'll probably be Calibration Laboratory 17025. But I will try and just have a look while we're here. Talk amongst yourselves.
Okay. Does anyone have any other questions? You can either go through the chat or you can actually ask them directly. I have a question myself. You said, okay, I work here in NHS in Scotland, and you said there's a push for accreditation in NHS England, Laura. Do you know what's happening here in Scotland? Because it's quite, when I speak to people, no one really seems to know.
Yeah. With MPACE, I can't say that that there's a lot of noise going on in the devolved nations. Certainly with IPEM, the health boards and chief scientific officer, they've been looking at, because of the issues around NHS Lothian and paediatric audiology, the assurances with IPEM and trying to look at what quality assurance should they have. So there's a review paper that came out of that suggested that accreditation was the direction of travel that they need to take. I think the challenge is, like I'm sure everybody will be thinking here, is where's it all coming from? The resources, the money, the time. That's the problem. And I guess that's where we're trying to sort of encourage the higher level executive trusts for you guys to have conversations with them to say, you know, accreditation needs to be provided and underpinning all of our diagnostics. Let's look at putting together a case to work together. So I think at the moment with Scotland, I know we certainly have one applicant for IPEM in Scotland, and they're slowly moving forward for audiology, but they are still, they've had conversations with us at UCAS and we've explained the situation, but whether we're going to see any trajectory anytime soon, I couldn't tell you. Same across Wales and Northern Ireland as well. I think Northern Ireland tend to wait a little bit to see what happens over here, and then they choose to decide what they want to do.
Okay, thank you.
I've just popped in the chat. It is 17025 is MPL.
Yeah, I guess you can all see the chat window. I'm sharing my screen and I've popped it there. Does anyone else have any questions at all?
I've stunned everyone into silence, I think.
Yeah.
We're very happy to take questions outside of this, so please, you know, feel free to just email us. You know, really happy to have conversations.
Yeah. One question I had is if a service had Kirsten's raised her hand.
She has.
That's fine. No, you can go in with your one, Duncan. You'd started. On you go.
Okay. No, I was just wondering if a service had been accredited but then had accreditation taken away, would they still be able to offer that service, or would it just be a non-accredited service?
Yeah, that's exactly it. So we can't, accreditation doesn't stop an organisation providing that service. It just means that it's not, can't say that it's accredited. Having said that, we have been doing some work with NHSE, so I know it's England again, so you know, apologies for that, but where we might be looking at having memorandum of understandings to share information from assessments, and where activity has been found to be unsafe or, you know, a significant non-conformity, there is an expectation that we can discuss that with regulators or with providers or with anyone else that means they might have to cease that activity or look at something being implemented.
Okay, right. Thank you.
Sorry, I'm just having a quick look in the chat because there was something just gone by there. So there are many ISO 9001 management system. Yeah, presentations seem to focus on small areas of activity, cost, straight benefit. So ISO 9001 is just the management system requirements. So that will be, lots of organisations will probably have that in place, and probably, you know, your medical physics and engineering organisations, your services may have the management system. That's a benefit to you with accreditation for the actual activity. What we're looking at from IPEM and MPACE is obviously a wider scope, so it's looking at the physical delivery of that activity rather than just the management system. But if you have got 9001, that makes life a lot easier, and it may well reduce the costs in IPEM and MPACE assessments because you've got a management system that's already got that assurance. So there's ways of working around that. I'm not sure whether that answered your question, Ted. Apologies, yes or no. Joanne said, if aiming for accreditation with multiple services in the same trust, does there need to be completely, yeah. So that's always a challenge. In an ideal world, yes, if you're going to be coming together with, you know, vision science, audiology, GI, whatever, all together, to make it the most optimal harmonious assessment, then ideally you want the same management system, documentation and processes. I think what we've seen the challenge with IPEMs, particularly because we have got a lot of organisations now coming forward with multiple disciplines, they have had to have a management quality manager or someone in place to try and make sure that most of their processes are aligned. In theory, when you look at the standards, a lot of the standard statements should be in place anyway through the trust, like patient information, feedback systems, things like that, facilities, all of those sort of generic things. Organisations and services should be following the corporate processes. I say should because sometimes we find that doesn't happen. Where the challenge comes is obviously clinically, when you're starting to think about a competency process, you may find that individual disciplines have developed their own process of assuring competence, whereas actually it would be much better, again, to think about from an organisational approach, how can you put in a competency framework that actually can be delivered across all the different diagnostics, but obviously with the peer review would be looking at specific clinical activity that would be specialised within that framework. So there is a bit of work there if you do want to come forward together to have as much of a harmonisation in your management systems as you possibly can. Doesn't mean to say that you can't come forward if you're not completely aligned. It's just that might be more challenging, and we might raise mandatory findings because we're seeing differences across the standard. Such activities. So benefits of ISO 9000 importantly covers patient data pathways, how to envisage applying MPACE in such activities. I'd have to probably go back and put that onto Gilda, unless Liz can answer that one. She may have more insight than I have. It's not my area of expertise.
Let me just pull that up. So I'm just, I'm not sure I quite fully understand the question that you're asking there.
Ted, if you want, you can actually ask directly rather than typing.
I think the problem is that the oncology systems are complex and we have good relationships across the departments, and we can follow patient pathways and the parallel data pathways. And we put a lot of time and effort into these ISO 9000 systems. And to be asking us to take little bits of medical physics and deal with them in a separate system doesn't seem to be the most cost-effective way of developing systems.
Okay, so I think that's what I was trying to get at before, is that where you've got your ISO 9001 or any other 9000 series, that would be taken into account when you're having your MPACE assessment. So there would, if you've already got that, there's going to be less effort that's needed, and it's more going to be the focus on the clinical side of things. But that would have to be a discussion that you had when you came forward. And I guess it's trying to understand what is it that you as an organisation and as a professional body wants to get assurance around, because obviously the 9000 series will only give assurance around certain elements, not necessarily the clinical practical side of things.
I think part of the problem is we need to try to work out how we can provide a cost-effective service to the NHS. And if we put a lot of time and effort and money into these schemes that you're promoting, it seems to bring less benefit than if we look at an ISO 9000 system and say, is there anything here that needs external attention, additional attention? When you've got a number of ISO 9000 systems that are linked to a named scheme, CHKS, I think, something like that, and CQC recognises them.
Yes.
They don't recognise all the ones who've got ISO 9001 in radiotherapy and oncology. and you've been doing this thing with BS 70,000 for 10 years or so, and you've got 2 departments, 3 departments. I just don't quite see whether this has got leverage and how it's going to develop.
I think from my point of view, just having done some technical assessments so far. So, for example, on equipment acceptance, commissioning, that side of things. So your quality management system, ISO 9001, might say we actually do acceptance and commissioning, and that there should be a commissioning report. But so this MPACE will actually then look at, well, what is in your commissioning report? Is there everything that we would expect? Does it look at the uncertainties of measurement? Does it address any risk in bringing that commissioned piece of equipment into clinical use? So that side of things is covered by MPACE, which wouldn't be covered in a quality management system. Another example might be that, you know, all the staff have competency records. That might be the statement in your quality management system, but it wouldn't say, well, to what extent are those competency records there? You know, does it cover all of the aspects of your service, or are there gaps, for example? So I think in that sense, the MPACE brings an added dimension to just having a quality management system.
It depends what's in the quality management system. I mean, if anybody installs a new linear accelerator, they obviously have commissioning, and they don't just commission it themselves and say that's fine. They commission it, and then they get another person come along and check that the measurements are correct.
Yes. Yes. So I think from my understanding, so the ISO 9001 will say that those things have to happen. But during an assessment for ISO 9001, the assessor probably wouldn't look into the amount of detail in an external visit, for example, and they wouldn't necessarily look at the actual results of that audit visit and say, well, are they what we'd expect? So yes, I would back up the use of accreditation to MPACE.
Well,
I think what we've seen.
If you looked at it from the other side, it means that we've got to pay lots of money to have small additional checks that you're offering. That the bulk of what we do is already covered in the system.
And I think what this is the conversation to have when, you know, you want to potentially think about it, is those combined assessments. That's what we're trying to look at, to make sure that, you know, where you've got assessment processes in place, they can be cost effective. But I think the challenges come from, as Liz says, and certainly from what I've seen from my IPEM assessments, is actually observing the practice physically and looking in more detail at the outcomes of what is being delivered has brought up some significant concerns, and just looking at management system and saying something's there and documentation doesn't necessarily capture everything. And we've seen lots of quality improvements that have come out of obviously the accreditation schemes from MPACE and IPEM. MPACE has only just started, really. Only, as we say, 2017 was when the standard came out, but the actual scheme has only been going for a few years. So we've yet got to sort of see more trajectory moving forward. But certainly, you know, if you've got questions or things like that, probably best to take that outside of what we've got left of. We're over already the meeting, but very happy to chat about that.
I was going to say, yeah, I'm conscious our time has overrun slightly. So I think, yeah, if you do have further questions, if you could contact Laura or Gilda or directly. The recording of the talk and the slides should be available on the IPEM website after this. I think I'd like to thank Laura, Anne and Liz for doing the presentations, and I think we will end here. So thank you, and thank you all for attending.
Yeah, thank you very much. Thanks for having us. Appreciate it.
Well,
Take care.
Thank you. Bye-bye.
Bye.